So I have the distinct honor of introducing Dr. Carol Cain, who is the Executive Director of the Center for Clinical Information Services and Kaiser Permanente's Care Management Institute. She oversees Kaiser Permanente's national guidelines, clinical library, clinical education, quality informatics, and the Garfield Memorial Research Fund that helps Kaiser fulfill the promise of a learning healthcare system, which I know is something we all aspire to. She has helped design patient-centered pathways for the transition from hospital to home, which is one of the most complicated things to deal with, managing chronic pain, oncology treatment, precision medicine, and other chronic conditions. And she's currently co-coordinating Kaiser's approach towards the responsible use of AI in healthcare delivery. She is a clinical informaticist by training, and she's also led courses for my home program, which is the biomedical data science department. So please welcome to the stage, Dr. Cain.
Thank you. I might, yes. It's great to be here and back. So delighted to see everyone and delighted to see this moment in healthcare. I'm here today to tell you a little bit about a large-scale quality assurance effort that we did at Kaiser Permanente just last year. It was a big year last year. It's not an evaluation of the technology, but more around how we managed to get our system to really all sorts of folks across the organization to work together to fulfill our responsibilities toward using AI in a patient-centered way. So for those of you who don't know, Kaiser Permanente is an integrated care delivery system. We're both an insurance plan and a medical group. We have members, 12.6 million members. Those are our guiding lights, and are in 8 regions. So you can see the regions here on that map. With 25,000 physicians in multiple specialties. And so that was one of the things that we were really thinking about as we were using this technology. I mentioned this, both to give context, but also to say that our challenge was that as we were trying to deploy across our entire system, we really wanted to test and use this technology in all of our different contexts. And we knew that at the time, so this is about January of 2023, that there were, even though some of these models had been piloted and had really good data behind them, had not been used in the variety of real-world clinical settings that we needed. And so it was really a chicken and egg question of how could we get the data that we needed to evaluate if we were nervous about deploying it widely. So that was the challenge that we had, and we're gonna, for today, I'm talking about this case example of AI-assisted clinical documentation tools, so what people are commonly calling ambient AI scribes. This is a voluntary technology, so first of all, the physician, the clinician user has to choose to use it, and that was actually a big source of comfort to us because we weren't, forcing it on anyone. And then the second step that was really important to us is that the patient needs to give consent for the use of for the recording, for the use of the tool. After that, the clinical documentation tool, the vendor we evaluated was Abridge. It securely summarizes medical information from spoken conversations, from a visit, a primary care visit. And I want to pause here and do a shout out to Abridge for their collaboration in this evaluation. The panel earlier talked a lot about partnership, and that was certainly a really big part of our work here, is their willingness to be transparent, to tell us about their models as much as they knew, and then to participate in evaluation together. When we went and did the evaluation, we kept a little bit of an arm's length distance from the vendor. And so in many ways, we were doing an evaluation and they were doing an evaluation at the same time, and we would compare notes. So the tool summarizes the medical information from spoken conversations and then crafts a draft visit note for the clinician. The clinician can also see the transcript of the conversation and listen to the audio recording. The clinician edits the note before signing the encounter. And as with our other technologies that support documentation, the final responsibility remains with the clinician. So the benefits of this technology are that we were hoping to alleviate documentation burden on the clinician. I think folks have seen that now, and renew the focus on the clinician-patient communication. So this is our timeline. It was the fastest technology deployment that I've participated in my nearly 20 years at Kaiser Permanente, and it looks very neat here, but it was not neat when we experienced it. So prior to even fall 2023, we had actually experimented with a number of ambient scribe technologies and had decided that the time had not yet come. So for example, it would take 5 minutes for the technology to generate the draft note, and that was just too much of a delay in the workflow. And so we did have a successful pilot in fall of 2023, and I refer you to the paper here at the bottom of the screen from our colleagues, particularly Dr. Vinny Liu, who was also a Stanford graduate as well. And at that time, too, just to set context, we were really grappling in this industry with how we fulfill the responsibilities toward AI. Dr. Daniel Yang, who was right here, you'll be hearing from him later on. He had just joined our organization in fall of that year, and we were sort of looking at how we wanted to scale this technology really quickly. There was a big demand, lots of people were interested. The timeline that was laid out here was not necessarily the timeline we committed to. So what we committed to was doing a very quick evaluation to provide data for executives to make decisions. And then we also wanted to figure out how to distribute some of the decisions so that it wasn't all centralized. KP is a large organization, as you've seen, and there's a lot of regional variation that is merited, different markets, different arrangements. So we wanted to strike the right balance between centralized decision-making and responsiveness to local work. And so the work that's described in the paper goes between January and March of 2024. And oh my goodness, I have 3 minutes left. Well done. So and then in summer of 2024, we transitioned to established processes. So the request, as I've described, is to design a quality assurance evaluation to assess the quality of the draft note, but not of the final physician note, and to gather feedback from real-world contexts. And then what we wanted to do was leverage KP's experience in large-scale technology implementation, importantly in our quality and safety infrastructure that already existed, and in KP's local, regional, and national leadership structures. Not talking today, but we also did an end-to-end workflow analysis of safety risks using a failure modes and effects analysis. So we took a multidisciplinary approach. We took starred ratings of technology performance. This is, at the end, when you get the draft note from the vendor, you're able to say how many stars. You're also able to give free text comments. And then we wanted to do structured reviews of note quality. I'll explain that. We did qualitative analysis of user feedback across all the different ways that we were receiving it, including bug reports. And then we did some targeted assessments. The star ratings, first of all, gave us a lot of comfort. There were only 7% of notes that were rated 1 or 2 stars out of a total of 9,000. And about 14% of encounters, we actually got a star rating, so that was really high as well. And we did a look to see whether if people gave free text feedback, if their rating was likely to be lower. And as you suspect, it was. We then thought, well, this is a convenient sample, so let's make sure that all of our early users, so we had about more than 1,000 early users, and we asked them to do structured self-review using a tested, validated instrument for assessing human scribes. So this is the Physician Documentation Quality Instrument, PDQI. It was originally a 22-question instrument, and we slimmed it down to 5 questions by looking at which questions had the most variation in feedback. And we were similarly comforted by the quantitative data. So overall rating was about 4.35, 5 is good. And we were worried, for example, in this last point about whether or not the note was free from bias. So while this is not a rigorous bias assessment, it is a crowdsourced bias assessment among so many users. And we were really comforted by how few users felt that the draft note had bias in it. Mostly, the lowest scoring ones were whether the note was thorough and whether the note was accurate. And then we had all of these free text comments, 3,600 of them, and we did an inductive thematic analysis of them to try to understand some of the insights. And we list some of the insights in the paper, but you know this technology moves so fast, many of these insights were addressed immediately. And that's actually part of the point of the paper, was that we had a tight relationship with the users, we had a tight relationship with the trainers, we had a tight relationship with the vendor. And so many of the insights that were coming out were addressed almost immediately. They included themes like omissions and oversynthesis, and this is an actual, this is the kind of report we were producing for our clients, the executives, the users, the trainers, the vendor. And then we would say, you know, here's some risk mitigation, recommendations for risk mitigation, and then here are some model improvements that we put forward before the vendor, and then we had sort of a prioritization process in terms of requesting it. The second one we'll call out is that it was diarizing incorrectly when there were multiple speakers. So if there were 2 people in a visit and somebody was talking about their husband's symptoms, those symptoms might be summarized as part of the patient's symptoms. Then what we did with this analysis is we also then did some targeted assessments. We were curious and about probing encounters with more than 2 speakers. We also probed some dialogue in languages other than English. We have many bilingual providers in our system, and so many people were giving care in languages other than English. And then we did a pretty in-depth analysis in medical specialties so that we could give information to specialty leaders about what particular issues might be arising in their areas. These were incorporated in training, collaborated with the vendor, and then used for deployment decision-making. So back to that timeline, in March of 2024, we went to the executive sponsors with this analysis, and we had the 13 themes, we had the 3,600 qualitative comments, we had all of the PDQI results and the star ratings, and we said, how would you like to proceed? And at that time, the demand was really high. And they decided to do 2 things. One was, we felt like it was, the risk was low enough as a documentation support tool that we could roll it out to all of primary care. So we did that in March of 2024. Any primary care physician in our system could get a license. And then we maintained control over licensing, but we asked the regional leaders, the chiefs of surgery, to do a specialty-specific review of a report that we produced for them, and then have their specialty sort of discuss whether or not they were ready. And so then when they were ready, they contacted us, we would issue the license. So it was a way for having sort of operational visibility into what was happening while delegating decision-making to the regional and local level. And then in summer 2024, we transitioned a lot of this work, which had been centralized, to a fairly small team, notwithstanding all of the people who were collecting the data, and transitioned it to some of our established processes. And then I'll point out to you, we're very happy to report that we have ongoing evaluation, including a paper that was recently published in NEJM Catalyst about our learnings after 1 year. So I'll come to an end by thanking my co-author who's we are co-first authors, Anna Davis. She's on the phone here listening in. And then the second group, the Quality and Safety Working Group, we weren't even official enough to have a real title. And then the executive sponsors who commissioned this work, the geographic implementation teams, including Dr. Lee, who's here in the audience, and the evaluation team at Abridge. But finally, and most importantly, the 1,300 physician users who submitted data, who leaned in, who gave feedback to this implementation process. Thank you. Absolutely. So in the beginning, so first of all, we built on an established structure. You know, we had medical centers. In the departments, they'd have department technology leads. Those people were usually the people who got the first licenses to look, and then they would nominate early users. So the 1,300 users that we had, they nominated. We had mostly centralized training, but they were the ones who were sort of translating that training. And then they were the ones who were monitoring. We had group chats. We had a lot of assistance at the elbow. And then we were asking them to collect some of the structured data. They collected data long after this study report was over, especially as we were looking at specialties. And then we're continuing to meet monthly as a national group to look at, as the model evolves, issues that have come up. They're sharing the kinds of more in-depth evaluations that they're doing more on the local level. So we owe a great debt to them. All right, thank you.
That was awesome. Could we have imagined this even like 3-4 years ago, happening so quickly? So next we have Dr. Daniel Morgan, who is an infectious disease physician and epidemiologist. He is a tenured professor of epidemiology and medicine and the director of the Center for Innovation in Diagnosis, and acting director of the Division of Genetic Epidemiology and Clinical Outcomes at the University of Maryland School of Medicine. If those titles were not enough, he's also chief of epidemiology at the VA Maryland Healthcare System, where he cares for infectious disease patients. He developed testingwisely.com and the Bird Game, and he's headlined meetings at the WHO and the CDC, and hopefully he'll say AIMI in the future. And his research looks at probability in medicine, medical overuse, diagnostic stewardship, and AI. And he has won many, many accolades, including the NIH New Innovator Awards, the Shea Mid-Career and ACP Alvin Feinstein Awards. And of course, he has published in many of the top journals. You know their names, New England Journal of Medicine, JAMA. So we are very lucky to have him here. Take it away for us.
Yep. All right, I'm flattered to be here speaking with you, and I'm going to talk about a much more kind of applied subject, I guess, of how we are trying to explore AI use in the VA. I am on vacation, though, from the VA to be here with you, speaking, of course. So acknowledgements, this is in collaboration with the VA National Institute for Artificial Intelligence, and others there. There's no commercial COIs. There was previous grant funding from agencies that previously funded research. And, but this is an operational QI study. This was trying to see how well this could work for implementation within the VA. So this was remarkably fast and enjoyable to do, unlike a lot of research studies, because this was trying to just see how well we could use this for operational benefits. Okay, so a little bit about the details of healthcare-associated infections, and the one that I'm focusing on here, which is central line-associated bloodstream infection, or CLABSI, as I'll be repeating. So it's relevant in that it's one of the early healthcare-associated infections that we talked about reporting, and it's when pathogens enter the bloodstream through a central line catheter, and it's associated with a high mortality rate. And more importantly for this talk, it's a metric that is, unlike some of the metrics that were discussed earlier, you know, for internal use and for sort of really monitoring what happens. This is about the idea that if you collect a metric, you report it publicly, you change reimbursement based upon it, you can improve care. So this kind of the no hospital left behind approach to healthcare. And so this means there's a lot of interest in this metric. The problem is, one of the problems is this is difficult to collect. It's based upon chart review. So there are human experts at each hospital, usually nurses and then physicians, who will review this. And there's a lot of pressure to not report these because they, ding your hospital in some way, and your leadership pays attention to this. And it's known there's a lot of variability from site to site, and how well people adhere to the rules is often variable. And the rules are so complicated that it's easy to excuse somebody for, missing one or not applying it correctly. So people have looked at generative AI for this. There's a few studies using just the ChatGPT 4.0 chatbot. And so because it's you can't put privacy protected data in the typical foundational chatbot, these were done with not with real patients. So there was a small study looking at some CDC training scenarios for CLABSI and a related healthcare associated metric, CAUTI. And it was perfect on those, but they're not a very high bar because they're training scenarios. And then a small study was done here by an infectious disease fellow, Guillermo Rodriguez Nava, that I worked on with him, where we looked at a small number of cases, 20 CLABSI cases and 20 bacteremias. And that's like the trigger for a CLABSI that you start the review with and then you exclude it if it's negative. And it looked like it performed pretty well. So there was not a lot of work done in developing prompts or training the model. And it could pick up most. It had a 90% sensitivity, and then it was pretty good at saying they were not a CLABSI, if that was the case. And most importantly here, it took 5 minutes to do this versus the typical review, which takes over an hour. So based upon that, the VA got interested in trying to do this in a larger level. And the VA is slow in some ways, like we're talking about looking at ambient AI scribes soon. But in other ways, it seems relatively fast in that they have a pilot program where GPT-4 is available for people across the country in a privacy-protected way where you can put clinical notes into it. And so we started out, we recruited sites, we had 11 VA sites where infection prevention nurses and hospital epidemiologists agreed to do chart reviews, and they provided their data. So they sent all of their data for 3 years, from 2021 to 2024. We selected 110 cases, these CLABSIs, and 110 controls. So they were at risk of CLABSI but didn't develop CLABSI. And we standardized the prompts, and then we extracted all the necessary data. So this is really a proof of concept using a chatbot to mimic what you could maybe automate later. And so we extracted the data, which was not a quick process, and we sent them kind of in a bundle, like in a Word document, essentially, the notes that they were going to be including. They were blinded to the CLABSI determination because we sent them to other sites. And we had 3 different categories. We had a traditional expert, like a repeat expert review, just to look at how much variation there is in the standard method from one site to another. And then AI only, where we fed it these prompts and the data. And then an AI assist. And unlike some of the other studies that I know Ethan and others have done where they gave access to a chatbot but didn't say how to use it, we gave the output from the chatbot and then said, starting with this, determine whether you believe this is a CLABSI, and question that the GPT is needed, so you could ask it questions since it had the notes uploaded already, or you could go to the electronic health record for further questions. And we're trying to look at accuracy and efficiency. So these are the sites. We had a reasonably good distribution around the country. As many studies, it tends to centralize on the Northeast. And this is the primary outcome. And this is looking at accuracy. And I'll talk about the numbers for a minute because there's some FDA guidance. We couldn't say sensitivity and specificity exactly because we didn't have a gold standard for all of these. But I think the key part to notice is talking about overall agreement on the far column, that there was similar between each method. So a repeat expert review was similarly good as the AI alone or AI assist. And then when we looked at, so that was just agreement. Does the AI agree with what the original reported HAI was? But we know that the original standard is not great either. It's an imperfect gold standard. And so we looked at the errors, and you can see that's the 58%, that the majority of these cases, when we had 2-person expert review look at them, the AI assist did better than the original review. So it looks like it's a little bit better. They're all similar, I think. And these are small numbers, so when you do confidence intervals, they overlap. But it gave the impression that they were similarly good. And this is a little bit in the weeds, probably for people who actually, who don't do this type of thing routinely. But it's worthwhile noting there were a few more errors on with the initial expert review compared to the AI assist. And some of the errors were relatively simple things, like being present on admission is an exclusion from the criteria for having one of these. And that just means the blood culture was positive in the first 2 days. It should be pretty easy, but yet it was missed sometimes in both groups, as well as if there was a central line or not, which would seem to be easy also, but there's not a field in many electronic health records, not in the one we use in the VA. So this is based upon notes, basically, and it can be hard for doctors to figure it out when they're looking at the chart. So we also asked the experts who were doing this what they thought of it. So these are the infection prevention nurses and hospital epidemiologists. And so we recorded how much time they spent on each case, and it was faster, even with the AI assist, where most of them did open the electronic health record because they were cautious and they wanted to confirm details. So it took about 14 minutes versus 25 minutes. And notably, that 25 minutes is pretty quick, and I think that's because these people were doing this as a voluntary basis and they didn't need to report the numbers for their hospital performance. They were just trying to get a rough sense of it. But they also thought this was easier. The perception was that this took little or no effort compared to traditional review, and that it was at least as objective as the traditional review. We wanted to look at variability, some because we know that there's a lot of site-by-site variability. And so the lighter yellow bars are representing the traditional expert review versus the orange bars for AI assist review. And so there's some indication there may be less variability, which is part of the hope. Instead of having, we had 24 experts in this study who were reviewing these charts across the 11 sites. There was, one AI basically that was doing this with the same prompts. So we would expect there'd be less variability. And we surveyed people after, and almost all of them responded. Most of them have not used GAI before, so it was kind of a new process for them. But they liked it. 95% reported they liked the AI output. 100% reported they would use this tool if it was automated. But 90% felt the need to confirm this AI using the electronic health record. So they enjoyed it. They said it made their job easier, but they didn't fully trust it autonomously. Okay, so in summary, it seemed like it was, there's similar accuracy across all methods, but AI assist was the best absolute numbers and what experts wanted. AI methods seem to be more efficient and less variable. And an interesting thing that emerged from this is GPT-4o, which is the most advanced model we have access to in the VA right now. It's very good at extracting data, like it can tell you the dates of when the patient had a line in place. It can tell you a lot of information about their symptoms or secondary infections, but then it will misapply kind of simple rules. It won't kind of say, like, follow a simple algorithm to say, like, it was within 2 days, therefore this does not count. So it actually, if you can present all of that data as the output from the GPT, it aids human assist review quite a bit, just to be able, humans can look at it and say, well, that doesn't qualify. I'll exclude it without needing to open the chart further. So this gave us hope, and within the VA, we are trying to work on developing a pipeline for making this more standardized. Interestingly, you have to use a lot of structured data because it's too much data to use large language models on, so we're trying to use semi-structured data up front. And this seems like it may work for other healthcare-associated infections and quality metrics that we do. And the goal is really to have nurses and doctors have more time at the bedside and less time in front of the computer collecting metrics. Thanks for your time.
Thank you for that presentation, Daniel. I'm just curious, what would it take to take this proof of concept and scale it across the VA and just have this be the operational, whether it's AI alone or AI assist? Like, what are the operational barriers to doing that?
The VA is an interesting place because probably some of the barriers are different than in individual hospitals that are comparing themselves to each other. And the VA is interested because there's potential for this, I guess, as a use case, because this won't impact care nearly as directly as like a diagnosis calculator or something. But right now, the first steps we're trying to work on is just figuring out if the AI can be kind of scaled to develop a pipeline. But I think after that, it would require the different parts within the VA, the National Infectious Disease Service, the quality group, to really focus on this would be the format for reporting, or at least part of the reporting structure.